So now I'm going to talk to you about the Johns Hopkins evidence-based practice model.
Johns Hopkins Nursing Evidence-Based Practice Model was developed by Johns Hopkins Hospital and School of Nursing with the goal to bridge the apparent gap between the implementation of research and evidence. They did this by creating a model that empowers bedside nurses to use tools that accelerate the transfer of knowledge into practice clinically, administratively, and educationally. The model is dynamic in that it considers internal and external factors, as well as varying levels of nursing research. This process is done through PET, practice question, evidence, and translation. These 18 steps are processes of the Johns Hopkins EBP model. It is key to define and evaluate the question and form a team with a leader and a timeline. The evidence portion, the team is searching, critiquing, summarizing, and rating the evidence found. The team then formulates a recommendation based on the evidence. Steps 11 through 18 involve the evaluation of feasibility, action planning, implementing, evaluating, and reporting the change while securing support from decision makers. The following tools are to guide nursing teams through the process. Appendix A is used to help coordinate a task force. Appendix B will then help the team formally develop the clinical question. Appendices E and F are tools to appraise the evidence found based on whether it is classified as research or non-research. Appendix H is used to synthesize the evidence and helps to organize recommendations. It is important to examine examples of how nurses have used the model for actual projects. Coordinating with the articles we shared within the Week 6 material, Maury utilized the Johns Hopkins model while trying to decrease the incidence of MRSA surgical site infections and total knee and hip arthroplasties. Bucko, Robinson, and Bell completed steps 1 through 18 to synthesize recommendations and the evidence in order to decrease urinary retention and distension in postoperative patients. An integrative review of monitor alarm fatigue was also completed by employing the model. As you can tell, the Johns Hopkins Nursing Evidence-Based Practice Model is applicable and well-suited for use in many clinical areas and across the nursing profession.
Okay, so that was another model of evidence, okay? So national guidelines are benchmarks. They need to be quantifiable measures. So what practice change are you going to do and how are you going to measure it? You have to be able to compare numbers or put it into some sort of number. So if you're doing patient satisfaction, you have to be able to put it on a scale so that you can compute the numbers. Need to know the difference between your practice and national benchmarks. There's guidelines.gov, the AHRQ, National Guidelines Clearinghouse, CMS. Every medical and healthcare facility organization has some sort of benchmark it needs to meet. So barriers to evidence-based practice. Overwhelming patient workloads, misperceptions about evidence-based practice and research, lack of time and resources to search for and appraise evidence, organizational constraints, lack of support, peer pressure to continue with practices that are steeped that way, that sacred cow idea. So knowledge, there's lack of knowledge, unfamiliar with guidelines. Attitudes, I mean, this I think is the biggest barrier where I work, is attitude and behavior. It's really hard to get people to make changes. It's really hard to get people involved without the status quo. So finding those change makers, using that leadership, empowering and engaging others to get involved. So what are your experiences with change? Have you ever tried to make a change practice at your work site? What worked? What didn't? What was the final outcome? What would you do differently? And does evidence change behavior? So when evidence isn't there or not sufficient, so you could do this. I want to, when I had my son in California, a lot of the hospitals would not circumcise boys in the hospital because they said it disrupted breastfeeding. They told me it was based on evidence, so I had to deal with that once we were discharged, which is fine. I mean, it's my decision to do it. But they were telling me it was going to affect breastfeeding. So I went home and of course I got on my database and I started doing a review of LID on it and I couldn't find anything. It wasn't based on evidence. Now, they had a hunch. They saw some of their breastfeeding rates go up, but there was no evidence to support that. So what would need to be done is you would have to conduct a true research study. So when you're looking at research, you're looking at natures of phenomenon, right? And we've talked about, in research, they talk about the different nursing models and phenomenons. Who, what, how many, how much, What are the relationships among the variables? Is there a positive relationship or a negative relationship? And does one variable cause the other? So research questions, they reflect level of research seeking descriptive knowledge of the variables under the study. So that's a non-experimental design. The fourth question reflects a level of research that examines cause and effect. That's experimental design. Before you're going to conduct an experimental research study, you need to have data from 3 previous levels to support such a study. So some preliminary work. And if there's none, it's out there. You have to have some sort of previous work that you can extrapolate into your new work. And then value of research. It adds new knowledge to guide and improve nursing practice. So here's some differences between the QI versus research. With QI, it's rapid cycles of improvement. There's really no risk of patient because it's standard of care. Your audience is your organization, whereas your audience and research is the scientific community. And you might be doing changes just for research sake, whereas QI, you have a clear aim and outcome to this. And it might not be, it's not generalizable, right? What you do in your QI study is not going to be generalizable somewhere else. It can be somewhat generalizable, but research is research. That has to be able to be done in the same exact setting somewhere else, okay? There are there's several ICU hospitals in Cincinnati, and what one NICU does is not generalizable to the other in terms of quality improvement, but the research is generalizable. All right, and this is DMP versus PhD, so we won't get into that.